Go to the question here in the room.
Page 40, PAP, what is that is best able? I'd like that term to be more defined going forward, not here, but that needs to be defined. And then going down to bullet point 2 under that same frame under context, my question would be who or what? Because you're assigning a PAP to either a physician or physician group or an institution. And my assumption is that's data-driven. Doesn't say that, but that's the assumption. And it says payers are seeking input and have not yet made decisions. So my assumption is this isn't a decision, it's a data-driven decision, as has already been outlined. So that's the heart of the initiative, is based on patient care. Is that correct?
Bill, you want to comment on the structure of PAPs and how they're built into the algorithms?
The answer is not necessarily. A lot of it's just based on clinical logic, or we had an OB issue, and there were multiple providers, but the delivering physician was the PAP. We had total hip and knee surgery, and again, the orthopedic surgeon, or cholecystectomy was the general surgeon. And then we had something like we have congestive heart failure, acute congestive heart failure, or acute asthma, acute COPD. There you often will have an ER event blending into a hospital event, blending into potential readmission and discharge planning. And there the hospital became the PAP. And in this episode, we weren't sure, because you have a baby that's being cared for say a week or two. You have a lot of care being rendered by a physician. You have a lot of care being determined by the nursing or by the respiratory therapy. So you have a lot of costs driven by the institution and how it staffed the institution. It wasn't clear. So this one was a little murkier than some of the other episodes.
We've had a number of conversations with folks around the state, both individual neonatologists and pediatricians, as well as folks representing facilities, to really understand the breakdown of, typically what are the decisions that the different clinicians and different providers in this episode are responsible for. And I think what the consistent message we've heard for discussion in this group is that the physician, whether it's the neonatologist or the pediatrician that's primarily caring for the neonate, is making a majority of the decisions around the type of treatment that neonate is receiving. A lot of those clinical decisions, whether it be kind of the level of care, the exact services required, the duration of use, and kind of the specifications on ventilator therapy, all that sort of stuff, tests, frequency of tests, many of those decisions are going to be ordered by the neonatologist or the pediatrician. The subspecialist, potentially a cardiologist, surgeon, someone else, neurologist, would be either performing a procedure that's ordered by the neonatologist, would be consulting on that, etc. And then the facility also plays a substantial role because of the coordination of all the nursing for care for that neonate. And in many cases, the nursing staff will be carrying out treatments that are ordered by the neonatologist, or placing a central line and things of that sort. And so there's a real kind of there's a substantial component of this, which is the facility determining the most effective way to provide kind of quality, effective care for the neonate with the clinical decisions that the physician has made. And certainly charges and kind of the unit cost would be another component of what the facility is responsible for.
Therefore, is the institution generally the PAP in the neonatal setting, neonatal intensive care?
As Bill mentioned and Whit mentioned before, that decision hasn't been made yet.
Clarify also, and David, you may want to chime in here. Blue Cross and QualChoice and Medicaid have been working together to harmonize the incentives and the basic framework. Now, we are not working together to set rates. We're not working together to actually determine thresholds. Each payer has its own independence in determining, even the PAP, I guess, if necessary, but all the different commendable levels. And that's actually by law. I mean, the Federal Trade Commission would be on our backs if we started doing that kind of planning. So what we're giving you is the broad framework and the principles by how the decisions are made, but each payer ultimately will take the logic and make the final determination on their own.
Regarding neonatal care, certainly affected by before the baby is born. One, we didn't mention as a metric, for example, knowing Hep B status, HIV status, etc., which is not my measure to make, but hopefully something that I have to check off on. And hopefully they all, before they even leave neonatal care, that they would already have it. I know that we miss this. This is not 100%. I know that we do 100%, at least as far as I know, all the other screening things, but this one is probably the one that is most porous, I think, since we all, like maternal blood type, for example, if we don't have that, that may affect a readmission for hyperbilirubinemia, for example. To have that, that will affect this neonatal episode. So that's on their obstetric side. And then following that, I just wanted to also comment or ask the coordination of care. I don't know if that's related to, is it data driven to actually have better coordination? Does it really impact the outcome regarding before we get the baby or after we discharge the baby? Does better coordination with the pediatrician really affect our outcome? I don't really know that for sure. I know that it makes sense.
There are a couple of things. One, we actually do have some of those metrics in the perinatal. So HIV screening in the mom is part of the perinatal bundle or episode to do that. Let's just, for the sake of discussion, let's say a mom gets less than quality prenatal care, and then you inherit the child as a result. What that does, though, is that you now have a complicated child whose presentation would then be reflected in your coding. So, in some ways, the complications of that delivery and the presentation of that child becomes the trigger is the status of that child when you get it, as opposed to a reflection of what happened beforehand. So in some ways you're, as a neonatologist, a bit protected by that because the complexity of the presentation goes up because that's what you've received. So, there are all sorts of ways that comes across. But again, I think the more we coordinate with each other, obviously the more information the receiving pediatrician gets at discharge, the more understanding the mom and the family has about how to manage that child in their home community in the house is going to have a bearing on the outcomes of that of the care after or the course afterwards.
I suggest that the frequency of a great many of these things are done by the ordering physician. So lab tests, x-rays, all the things you point out. Level of nursing intensity is in part a consequence of that, and there are lots and lots of guidelines and standards about nursing levels that are really not very flexible, if you will, or not very open to arbitrary decisions on the part of I can't reduce nursing costs in our NICU by 40% just because I want to, because A, the docs will kill me, and B, will kill babies. And so there are things that get in the way of too much flexibility in there. On the other hand, the hospital has everything to do with what it costs to make an x-ray and what it costs to make a lab test. And if you could figure out some way to hold us respectively accountable, each for the part that we actually do manage, I think that would get you a long way down the road.
Which raises the interesting question, because some of these episodes are pretty pricey. And if you manage the practice variation, then who receives the gain sharing? And so the doc and his ordering is, relatively speaking, a small piece of the total cost of what's going on. So, you talk about risks and gain sharing. You might have discussions then about who is the PAP based on the fact that there is a fair amount of dollars on the table. Granted, I don't know what the practice variation would be like, but you could see where that starts to get into the issue of who is the PAP and who is sharing in the gains or at the risk.
Right. I think, John, you raised an excellent point. I mean, I think those are exactly sort of the tensions that need to be discussed. And I would also clarify that to your point about it being black and white, not being black and white, the COPAP situation is absolutely on the table as a solution, I think, that the payers would be considering. It's just they haven't made a decision either way. I would actually summarize on what you mentioned too, Bill. Some of the considerations we heard talking to folks individually. So if you have the facility as the PAP, to your point, there are a lot of things, or even the overall cost, the unit cost of many things that the facility really has a lot of responsibility and control over. But there's a tension of the physician is making ordering decisions, and so if the facility is the PAP, but the neonatologist or pediatrician is not directly accountable, how is that going to actually work? Conversely, if you have the neonatologist or the pediatrician as the principal accountable provider, and who makes a lot of the ordering decisions, but the facility costs they don't have direct control over, and some of the nursing configurations that are the result of their orders they have less control over. How do you think about that? And so that's where you would kind of naturally come to a place if you had both the hospital and the neonatologist group or the pediatrician group kind of jointly responsible in some way. I would call out, as the payers go down that path, the mechanics of gain and risk sharing would have to just be altered to ensure that the model is viable. So, for example, in the other episodes, it's been a set gain and risk sharing percent if you're above or below the commendable threshold. If just the physician is the principal accountable provider, given the physician group represents a relatively small component of the overall reimbursement, having that same level of risk and gain sharing would be much more difficult because the swings on a particular physician group would be much larger. And likewise with a COPAP, you would have to think about how to fairly kind of distribute some of the upside and downside and so on. So I think those are all the considerations that are really on the table for discussion right now.
Suppose that the physicians involved in the care of the neonates and the institution get together and decide how they would like to split up any incentive or any loss amongst themselves, then you don't have to decide who's the PAP. They both are. How about that one?
A good suggestion. Thank you.
We have certainly encouraged innovation at each institution and let 1,000 flowers bloom. So if that works for you, great.
This question has come up several times. Again, there's no proposal in place now for anyone to react to yet. The payers are still gathering feedback. So what we wanted to do today was just quickly walk through at least our understanding of the care delivery pathways in which a transfer would or would not occur and so on, and to get views from the room of what would lead to situations that we're seeing and so on. And then I think the payers will incorporate that feedback to put forward a design for how this would work. So if you look at page 44, this is the care delivery pathways for neonates that are more complex, so not the normal newborns. You'll see starting on the left with presentation of the mother. We started with two high risk deliveries where there's actually time to transfer the mother before delivery, versus high risk deliveries where there's no time to transfer the mother before birth, meaning they show up kind of at the last minute to a lower acuity or outlying facility. Again, this doesn't show why something happened. It's just mapping out the potential set of pathways that could happen. In the first case where a mother presents for delivery where there's time to transfer before birth, or there's been a clear kind of prenatal plan put in place recognizing that mother is at risk for preterm birth or a more complicated delivery, that mother could be transferred, certainly. And then you'll be at the top line where the mother is transferred and then delivers in a higher acuity setting. There's no necessary transfer of the neonatal required after delivery, and the neonatal care would happen in a higher acuity facility or the NICU. There's also from that same the case where the high risk mother presents with enough time to transfer before birth, where the mother's actually not transferred before birth. We understand from input from the last clinical work groups that this does happen at points in the state. And the mother actually delivers in a lower acuity setting, even if there was time in advance to have transferred that mother. And so delivery happens in a lower acuity setting. And then from there, in some cases, the neonate would be transferred to a higher acuity facility as necessary, whether it's by ambulance or by helicopter. And in other cases, the neonate might not be transferred, either because that lower acuity facility has the comfort and ability to manage that neonate, or for some other reason, and the neonatal care is done in a lower acuity facility. And certainly, back on the left-hand side of the page, if a mother presents and there was not time or knowledge in advance to prepare a plan to transfer, that mother would certainly deliver in the lower acuity setting if that's where they presented.
Okay, what about in the case of, say, back transfers? For instance, mom was judged to be high risk at 32 weeks, delivers a baby out at UAMS. Baby's actually doing fairly well, but has ongoing feeding issues that prohibit going home. But UAMS is full and really kind of needs to get rid of some of their lower acuity babies so that they can accept higher acuity. So they back transfer to one of the other hospitals. I don't see back transfers to the lower acuity setting listed in your episode of care here.
That's an excellent point. The care delivery pathway here should be we should show the complete set of back transfers. The question for the group is, do folks feel that there is a quality imperative there for either not enough quality and cost imperative for either not enough back transfers happening, such that there's not enough space being freed up for higher acuity babies, or are there too many happening? What are folks' sense of that?
Douglas, I think that's a good point. We didn't really think about that. We didn't have much time to go over that in the committee. And the other thought that I had was, should we reward transfers to closer communities? For example, if a baby at a lower acuity hospital in Fort Smith, or say Jonesboro, where you are, Douglas, if it's an appropriate baby for your institution, should we reward them for transferring closer to them rather than, say, transferring to UAMS or Baptist in Little Rock? So those were some questions that came to my mind on this. The other thing is, I think certainly we really feel like the payment system is completely bass-backwards with obstetrics, because they are not rewarded for doing the right thing, which is to transfer a high-risk mother, and they should be. So that's a problem that we'd like to have your input on. We struggled with that.
One of the first things that we found was that statistically across Arkansas, 50% of babies that need to be in a level 3 equivalent center are delivering in level 1s and 2s. You're, of course, never going to get 100%, but most states that worked at it have been able to get 85, 90, maybe even Rhode Island probably gets 95 or 100%. But a larger rural state like this, we certainly should be able to get to 85%. So that means that there are a lot of babies with the associated doubling or tripling of infant mortality that are delivering in the wrong hospitals, because we don't seem to have a process that drives getting the right mom to the right hospital for delivery.
Yes, I'd like to advocate for a metric that would include referral to early intervention for those kids that are at extremely high risk for developing problems that will need to be followed by EI. And that includes the chromosomal kids with known risk factors, the grade 3-4 IVHs that unfortunately we see.
And can you describe when would that referral ideally happen? Is it in the during the stay? Is it after discharge?
No, it's in the final days, just prior to discharge.
Send us some referral metrics would be very helpful with that, and I think we probably have those here, but it'd be something we could send out to everybody. That'd be good. In other words, who you would like to see.
To that, there is a general feedback email address that you can send all feedback to if you don't necessarily have Whit Hall's email. It is arkpii@hp.com. So that's ARC Payment Improvement Initiative at hp.com.